further ado today, I am definitely happy to be able to introduce our speaker who reminded me that he is the last of the COVID cohort to present in seminar here. So Abdulla Abdelaziz got his Bachelor of Science in Pharmacy from Minya University in Egypt. He has been a member of our graduate community for almost 2 years now. And as we noted, is a member of what they affectionately call themselves the Corona cohort. So I don't know affectionately. They call themselves the Corona cohort, maybe unaffectionately. Anyway, Abdulla today is going to talk to us about some of the work that he has done in collaboration with faculty and others in the Department of Pharmacy Practice, as well as some other graduate students in PSOP and some other people. All right, Abdulla, the podium is yours.
Well, thank you so much for the nice introduction. So it's my pleasure today to present my first work here in PSOP. And happily, this work has been accepted for publication. We're just like doing the final edit. Thank you so much. Okay, before beginning, let's do some acknowledgments. So I would like first to acknowledge Dr. Michelle Martin, who is a clinical assistant professor at the Department of Pharmacy Practice here at UIC. So she was extremely enthusiastic about this project and very persistent for this project to see the light. Also, I would like to thank Dr. Lee for his supervision of in this project, from whom I learned a lot, and I continuously learn. Also, my colleague who actually brought me in this project, Jonathan, also Nicole Waring and Jasmine Forrest, who were also contributors to this project. So let's get started. So today, my main points. So first, we're going to discuss some background about hepatitis C and some policies regarding receiving hepatitis C treatments in Medicaid population. Also, I will walk you through how we formulate our research questions, the methods, and then I will share the results with some points on the discussions and implications. Finally, I will conclude with limitations and conclusions. So let's do some background about hepatitis C infection. So, of course, like a lot of you know that HCV is one of the most common liver diseases in the United States. So this is based on the CDC recent statistics. We have about 14,000 deaths per year, and this is actually an improvement because in 2016 we had about 19,000 or 20. So we have some improvements there. Moreover, HCV is you have a lot of bloodborne infections such as HIV, which has a lot of notoriety. However, HCV actually is more common than HIV in the United States in terms of prevalence, with a prevalence about 2.4 million patients in the United States. For HIV, I think it's about 1.2 or something. And so HCV is dangerous, not because the virus itself, but it's because the complications. So the major complications for HCV, it's like developing liver cirrhosis and hepatocellular carcinomas, which account for about 82% of the economic burden of HCV. And about the economic burden, so this economic burden is estimated to be about $9.1 billion in 2024. So the bottom line from here that HCV is, as you almost all of you know, is serious. So just a little bit of tangent here. So this is not related to the United States specifically. So this is like the global distribution of HCV infections. You have this part, which is the Middle East. You have this dark part, which is Egypt, from which I come. So Egypt actually has, if not the highest prevalence of HCV worldwide. And this continues to be the case for a while. Until recently, I think 2 years or 3 years ago, there was this massive screening campaign for HCV. And in fact, I was part of this screening campaign, and the government actually is doing a good work in terms of forcing people. And I'm picking the right term, it's forcing. Yeah, so I remember that my father was told that you won't get your salary. My father was a government employee, so, like, you won't get your salary unless you get screened for HCV. And they did, yeah, so if you have, so autocracy can have some benefits, okay? So this is, yeah. So, yeah, anyway, so we can spend a lot of time talking about HCV epidemiology, but like I will pick the part that's relevant to our story and our research question. On this graph, you can see the time trend of the incidence of HCV by age groups from 2004 to 2019. This is the most recent from the CDC. So as we can see here, from 2004 to 2010, you don't have that much variation. And by the way, this is adjusted for case ascertainment and reporting, so you don't have this much of concern about detection bias or ascertainment bias. Okay, so from 2010, you have this sharp increase in almost all age groups, but the sharpness of increase is varying, or it's not the same, it's differential among age groups. So you have specific age groups that are highly impacted, and we will, so like, I just want you to keep that in mind until we revisit this, this trend, this trend. Okay, sorry about that. The second thing, or the second item is, so the risk factors of HCV. So here, as we can see, so this is a study that's like a little bit old, but it's widely cited in the literature. And here you can see the contribution of these risk factors of HCV, and the unparalleled risk factor for developing HCV is being an intravenous drug user, okay, to use these drugs or inject drugs or substance use. So you have this very large odds ratio, about 50, which like none of the other risk factors are even close to the quarter to this odds ratio. So you have, so here you have these age groups, these from 2029, 30, 39, and then you have this. So these are two elements of the story. So we asked this question, like, is it a coincidence? Like, we have these trends in these age groups starting from this point in time. So another piece of information that can help us understand if there is some relationship or is there some cause behind this is that. So this is from the CDC, and the CDC marks 2010 as like maybe the beginning of the opioid epidemic be more pronounced. So you have this date, and also there is another graph that I would like to show. It's not by age group. The color here does not represent the age group. It represents like the type of opioid. But you can see from 2010, you can see an increase in heroin use. You can increase, deaths related to heroin and deaths related to any opioid. Okay, so this is very much overlapping with the trends of HCV. So that's why we have this and this phenomenon known in the literature as opioid HCV syndemic. Anyway, so let's move to HCV treatment. So fortunately, HCV is curable, but there's no vaccine available for it. And recently, in the recent 2 decades or so, class of like group of drugs called the direct acting antivirals, which are acting on different parts of the HCV replication process. So these medications have dramatically improved cure rates. So based on the most recent statistics, that 95% of patients receiving these medications are actually achieving what we call SVR. So SVR is short term for sustained virologic response, which means basically after you complete your treatment course and we use PCR to measure HCV in your blood, we don't have any HCV detected there. I think it's measured 12 weeks or more after completing the treatment regimen. However, and this is like a known motto in policy research, so no matter how these drugs are effective or good, so we cannot hope for any benefits if these drugs are not accessible by patients. And here is the other part of my background, which is Medicaid HCV patients' access to treatment. So you have a lot of literature on the treatment access, but we're going to focus on Medicaid specifically because by definition they are socially underserved or disadvantaged, and they are like significant proportion or maybe great proportion of Medicaid patients can be also victims of opioid epidemic. So this is also another concern. So let's tell the story of a Medicaid HCV patient trying to get HCV treatment. So let's imagine this is a patient who is enrolled or covered by Medicaid, and he has been recently diagnosed with HCV, and now he decided to launch this journey, like he wants to take this medication. However, it's not that easy. So this patient should overcome some obstacles, okay? So we have some 3 doors, and this patient has all the rights to be angry. Okay, so these doors are some policies restricting the access to treatment. So number 1, we have fibrosis. Number 2, we have some prescriber limitations. And number 3, we have sobriety. So sobriety will be our focus, but let's just mention something briefly about fibrosis and prescribing. So for fibrosis, Medicaid is requiring the patients to achieve some degree of liver damage to receive the treatment. So it's kind of absurd, like, okay, so if you have been diagnosed early, no, you should wait until your liver achieves like good amount of damage, then you're going to take the treatment. For the prescriber, so not any physician can prescribe these medications, only specialists like hepatologists or gastroenterologists can do so. And for the sobriety, so for a patient to receive treatment, this patient should provide a proof that they are free of any substance use, alcohol abuse, intravenous drug use for a certain amount of time before initiating the treatment. So we think this is the most annoying door. So, and why do we think so? I will explain in a moment. So this is, these 2 maps are from the HEPC, stateofhepc.org website, which is like a campaign trying to push for removing all these doors. So this is contrasting the situation in the U.S. between 2014 and 2022. So the darker the color, the worse. So here you can see the restrictions are varying from requiring screening and counseling before getting the drug to like the dark color in which Illinois had in 2014 and removed in 2018. So the patient, a Medicaid patient in Illinois should provide a proof of abstinence for 12 months before getting the treatment. So now in 2020, the situation is much better. We don't have this 12 months. However, we have some restrictions varying from requiring screening and counseling to requiring a history of no substance use 6 months prior initiating treatment. So we still have about, I think, 15 states requiring some degree of restriction. So we think this policy does not make any sense. So, and why do we think so? So this is not the perfect conceptual model, sorry about that, but if we have this HCV patient, okay, we have HCV, and we have what the policy is related to, which is alcohol and drug abuse. So from the face value, you don't have, like, what's the connection? Like, there should be no connection. But using, like, the DAG grammar, so if we have the intravenous drug use here and some socioeconomic factors related to being in Medicaid, we know for facts, like from this large odds ratio, that these can be highly associated with HCV, and of course, these are highly associated with alcohol and drug abuse. So basically, large proportion of HCV patients will be automatically, although not causally, okay, of patients who are on alcohol abuse or drug abuse. So basically, when you are putting restriction on that, you are actually preventing HCV patients from getting the treatment they mostly desire. So yeah, so this is the conclusion. There's an overlap between people who inject drugs and HCV patients. And another piece is that clinical guidelines are actually against it, okay? So a lot of associations, and maybe I can quote you something they said. So the American Association for the Study of Liver Diseases and the Infectious Disease Society of America joint HCV guidance recommends against barriers to HCV treatment, and they specifically recommend treatment for people who inject drugs. So it's totally the opposite to this policy. And also, like, those policy advocates are saying that, oh, people who inject drugs do not achieve that much high adherence because of their, like, behaviors. So as a result, you have these, so, like, we should not waste our resources by treating these patients. But actually, this is also negated and nullified by the evidence from clinical trials and observational studies showing that people who are actually inject drugs are achieving good therapeutic outcomes in terms of SVR rates. So this is what led us to our research question. So why our research question is important? Because we still have some states who are imposing some restrictions. So we feel that if we can do some research to convince them to abandon this policy and to remove these those restrictions, that might help HCV Medicaid patients. And we had the data to do so. So Illinois, as we mentioned, they had before 12-month sobriety restriction for HCV medication coverage. But on November 1st, 2018, this restriction was removed, and they just replaced it with requiring some screening and counseling before getting the treatment. So our research question was, so let's do the comparison. Let's compare those pre-policy and post-policy, and let's see if they're gonna differ in terms of their therapeutic outcomes. So the P in our PCOS was Medicaid HCV patients receiving treatment before November 2018, and the intervention, which is the sobriety restriction policy change, the removal, and the comparator is the same population, but after November 2018, and the outcome is achieving sustained virologic response, or SVR, and our timing was from January 2014 to October 21st, 2020. This is the data that was available to us, and the setting was Urban Academic Medical Center in Illinois, United States, which is UI Health, basically. So I will walk you through the study design. So this was a retrospective cohort study, including Medicaid's insured adult HCV patients in UI Health. So, and this actually very representative of patients, of UI Health patients, because 40% of those patients are covered by Medicaid. But it's worth mentioning that HCV management in UI Health is following a clinical pharmacist-driven model in which, like, the clinical pharmacist has the largest share of contribution in selecting treatment algorithms and monitoring treatment and measuring treatment outcomes and ordering some lab tests, which is not the case in all healthcare centers in the U.S., of course. So our primary outcome, as I mentioned, was SVR for the group that was measured or observed before and after we removed the policy. So just a very small schematic. So this is timeline. We have the beginning in January 2014 and the end in October 2020. This was our separating line, November 2018. So we did not have much data or many patients in the post-policy removal era, but we have a lot in the pre-policy era. So you will have this imbalance in the sample size. So these were the pre-policy group, and this was the post-policy group. So the data that we collected from these patients, so we used data from electronic medical records from UI Health. We measured baseline characteristics 12 months prior treatment initiation, and these were the covariates that we collected information on. So we have the demographics, comorbidities, lab data, specific HCV genotypes, and also treatment history. And we classify this to historic versus recent, because not all the direct-acting antiviral treatment are the same. We have some varieties. So, like, as a function of time, some treatments were abandoned from treatment guidelines. So we thought that we need to account for this in our analysis. We also included fibrosis stage and also substance use. I will define these in a moment, like what do we mean by sobriety exactly, for like how did we operationalize these things. Treatment discontinuation and loss to follow-up. We have some information about that. Also, the exact direct-acting antivirals used, and some information about medication adherence. I will tell you now how we define that. So sobriety was defined as a composite of either of these events. Like, so if a patient was not either like if there is no alcohol use or intranasal illicit drug use or inhaled or intravenous, okay, so if the patient is free from all of this, we will consider this patient as sober, and this condition is ascertained or is detected in the last 12 months prior to treatment initiation. So a patient was classified as lost to follow-up if there is no SVR available after 12 or greater weeks after completion of treatment. So if a patient completes his treatment and there was no data about the SVR, so this patient was classified as lost to follow-up. Treatment discontinuation is a little bit different because, so in electronic medical records, you can actually capture this. So if a patient has discontinued the treatment, so the patient did not complete the treatment from the beginning for any reason, so we will classify this patient as treatment discontinuation. And for adherence, so we measured adherence like as yes/no variable with if a patient has missed at least one dose during the course of the treatment, this patient will be classified as like lacking adherence or not adherence. And adherence can come from either like self-reported data from the patient or by checking the dispensing pharmacy data if the patient did not come back to do the refills. Okay, so for the analysis, we ran some descriptive statistics to describe our cohort and to measure the differences in the baseline using like the appropriate statistical tests. Also, because we are, so yeah, I will talk about that, but we did not have like a lot of patients. So we calculated standardized effect sizes to see if there are some differences, not relying on the p-values. And this was the significance level, 0.05, and patients, so we had some missing data regarding the outcome. So when the outcome is unknown, we know that this patient either was lost to follow-up or had discontinued treatment. So to study the effect of the policy on the SVR, we built a multivariable logistic regression model regressing SVR binary on the policy variable, and we controlled for potential confounders. A confounder is defined in our study by using an iterative, purposeful selection process, and we considered two things here. First, the clinical relevance of the variable, and also if this variable is producing 10% change in the parameter estimate after adding it to the model and keep it out from the model. There was one exception here, which was the use of, which was relevant clinically and statistically, but was not included in the model because we thought that this variable is affected by the policy itself. Because like if a patient knows that the policy is requiring him to change his behavior, so maybe the patient will change his behavior, and this will affect his chance to get the treatment. So we did primary analysis, which include only the complete case. So anyone who discontinued treatment or lost a follow-up was removed from the analysis. And we did a bunch of sensitivity analyses to examine the impact of missing data. So in two scenarios, one scenario we treated all those who were unknown in terms of outcome as success, like the achieved SVR, the R1s, and another time we dealt with them as no's, like the best case and the worst case. Additional sensitivity analysis we made, so we did some restrictions or subgroup analyses. So in one scenario, we restricted the analysis to those who were sober in pre-policy individuals, and you might find this odd, like the policy is assuming that everyone pre-policy is sober. However, that wasn't the case, and I will tell you why. But here for now, so let's know that in the first analysis, we compared sober pre-policy individuals to those who are all individuals in the post-policy group, in the second analysis, we restricted the analysis to, again, sober pre-policy individuals, and we compared them to non-sober post-policy individuals, like to show the contrast. And finally, we excluded the pre-policy patients who received historic regimens, just to have this comparison only in those receiving the current regimen, because none of the patients in the post-policy group has received the historic regimen. So we did this exclusion. So now with the results. So let's start with cohort description. So in cohort description, we identified about 500, like exactly 496. Most of them were from the pre-group and like just a minority from the post group. They were similar in their demographics, sex, race, age distribution, previous HCV treatment experience. So there was not statistically significant difference. However, because the sample size is limited, we relied on the standardized difference to see if there are some differences, okay, not only the p-value. So here we can see that although in sex, race, ethnicity, all these variables were not statistically significantly different, but in the based on the standardized difference, they were different among the pre-policy and the post-policy. Here, this is like a caption from table 1. And as we can see here in the post-policy, you have more patients who are, for example, have like alcohol use, like you have about 45.3% of the post-policy having alcohol use in comparison to 26.7%. And that means the policy is working. Like more patients who had alcohol use and drug use are using the treatments. But there's still this mystery, like why do we have this? Why this is not 0? And the answer is actually very simple, but let's continue. As we mentioned here, there were like very significant minority of patients who were treatment experienced, like not, like it's about 3.7% in the pre-group and about 6.8% in the post-group. And by experience, we mean that they have these like very ancient regimens of interferon and ribavirin. Anyway, in the pre-group, and this is where the mystery is unraveled. So here we have 36.2% patients reporting substance use in the 12 months prior to HCV treatment. And this is from the pre-group. So the reason why, so you need to provide this proof to get the treatment. But once you get the treatment, you can just like, a patient can disclose that now he's returning to having substance use. So not all patients receiving the medication in the pre-policy era was sober. This wasn't the case. And in the post-group, we have significantly higher proportion because now, even if you're not sober, you can receive the treatment. For the loss to follow-up and treatment discontinuation, luckily, we don't have that much difference between the two. So they are similar in that regard. But, and this is kind of expected, the pre-policy and the post-policy groups differed in medication adherence. So the pre-policy group has higher medication adherence. So they have lower missing dose rates. So 18% of the pre-group actually reported that they missed at least one dose, while 26% of the post actually reporting missing at least one dose of the treatment. And this was statistically significant. This is for adherence. So moving to our regression analysis. So this was our primary analysis. Like we just restricted the analysis to those who had known outcome. And as you can see, we have like high SVR rates, regardless the group, which like very strong indication of how these drugs are effective. And actually, it brings problems to our model. Anyway, because we have very, very, very small zeros in the outcome. There were no statistically significant difference either in the crude model or the adjusted model. When we accounted for missingness, like when we dealt with missing data as all success or as all failure, the conclusion did not change. Also, when we vary in many scenarios, so we decided to only include like sober pre-policy versus all those in the post-policy. And again, the conclusion did not change. It's it's always crossing the null. So there's no change, there's no difference, there's no evidence of difference between the two groups. And again, we did the same imputation here for the missingness, and the conclusion holds the same. These are the results from comparing the sober with non-sober, like following the intention of the policymaker to see the contrast between the two, and the conclusion still the same. However, we have some problems in the estimation because the confidence intervals are too wide. And this was the final sensitivity analysis we conducted, excluding those using historic regimens and only restricting to available regimens. And again, it's the same conclusion. However, you change the cohort or the analytic groups. So the main takeaways from our analyses is that, okay, so from our description, we can see that the policy removal is working because more non-sober patients are getting HCV treatment. But there is no evidence, and this is suggested by our regression, of a difference between those who are receiving the treatment in the pre-policy era or the post-policy. Also, our conclusion was robust against missingness, although it was anyway small, but we tried to account for that in our analyses. And about adherence, so policymakers are right regarding that patients who are on substance use have compromised adherence. However, these medications are very effective, so this difference in adherence does not affect the final conclusion. So, and also there is, and we know this from our clinical experts in the paper, because there was this time effect. So before the policy, there was no much focus on measuring adherence. But after the policy, measuring adherence increased, so you can see that there is some kind of detection bias regarding adherence. So we don't have much statistics about adherence before the policy removal, but we do have about the post-policy. That's why we can see the difference. And this is not from our paper, but it's from the literature. So because this is also one argument that the policymaker is making, is that we need to save money from spending on drugs that some users, some substance use won't use it correctly. However, we can see from the literature that long-term benefits of early HCV treatment greatly outweigh the short-term savings from limiting HCV treatment access. It's about 12 billion of gaining by the long-term benefits versus the loss that we have of the 9 billion that we mentioned early in this presentation. So I think, yeah, so let's do the limitations. So unfortunately, we only have a single institution in our data, and it's run by basically clinical pharmacist model, which might not be the same situation in many places in the United States. So we have some issues regarding external validity or generalizability. Also for the analysis, because very small number of patients were not achieving ACVR, so I have a lot of zeros there. So this was limiting some covariates from being included in the model because the model won't converge. And also we have the problem of residual confounding. So we are not 100% sure that we have control for every aspect between the pre-policy and the post-policy. So I will finish that by quoting the conclusion from the paper. So Medicaid-insured HCV-treated patients at our institution had similar SVR rates before and after Illinois Medicaid sobriety restriction removal. These real-world clinical results may be used as a support for removal of sobriety restrictions for HCV treatment and future policy change. State Medicaid plans must cover treatment of patients with substance use to align with national HCV elimination goals, which is set by the WHO that we need to eliminate HCV by we are ambitious to remove it by 2030. And that's it. Thank you so much.
Questions for all?
The ceiling microphone.
Yeah. I'm turning on the ceiling mic so we can hear the questions from the room, but you're also welcome to ask questions if you're out in the cyber world.
I have one general question.
Okay.
And probably an
It's okay.
Second first.
Sorry
No,
about that.
it's okay, go ahead.
I put here the one from Lisa for every single slide, so your slide looks like that or anything. So, just general question. Did this study actually supported by the Gilead or any other entity, agent? So any kind of the funding for this study?
This is a great question. I think Dr. Martin has some, historically has some funding from Gilead and other companies, but we did not receive specific funding for this project.
Thank you. Just one question,
So I know like in the beginning you showed that actually the 20 to 29 years old patients are more, like they have higher prevalence of HCV. Yeah, so I understand why you focus on Medicaid patients, but I'm just wondering, do you think you will see different results if you focus on younger patients since they are more affected by HCV and then alcohol and substance use?
So the question is about if there's like differential treatment effect in these groups?
Do you think you will still see this null result in the younger population? Or do you think you maybe see something different?
This is a great question. So, so two parts. Yeah, I can get the question, but two parts. We did not investigate this possibility because the sample size to begin with is very small. So if we were to restrict it to those, to this age group, so you will have, you will have a lot of problems to fit the data to begin with in any model. So we did not investigate that. You might be right, but I don't know.
Okay.
Okay.
Yeah, really nice study, Abdullah, nice presentation. I was wondering about, and this kind of is related to Kibum's question, but it's a broader societal issue. So we're often feeling compelled by drug companies and even pharmacists feeling relevant in terms of feeling we've got this ethical responsibility to provide access to treatment no matter, you know, what condition the patient is in. And one of the contrary arguments to providing these treatments access to, because if they're, you know, a current drug user, for instance, is the concern that it's just going to be undone, this treatment, because people relapse, then they get hepatitis again, and then they have to be treated again. And I wasn't sure how much you considered the fact that patients, if you go back to jail, you receive the treatment, you get rid of your hepatitis C, then you share your needles again, then you get hepatitis C again, and that's part of the value proposition overall that needs to be considered. It seemed to me to be part of the consideration of the policy that they implemented in the first place. Your follow-up period is relatively limited, right? Because it's only up to, this policy was implemented in what year? Was it
2018, yeah.
And then you've only followed up to 2020.
Yeah.
So based on your analysis, is the potential for a lag effect of reacquiring hepatitis being adequately considered in your discussion and the overall value proposition for doing this?
Yeah, this is a really interesting point. I didn't think that deep, to be honest, about it. But like 2 points. So the first thing is, so we are guaranteed that this patient, like this substance use, will have this HCV clear period, and he might get another HCV. However, there are some benefits in this clear period because during this period, this patient cannot transmit the virus. So we are in some way limiting the transmission of the virus. So this is another benefit for giving access to these patients, although there's a possibility and a strong possibility that they will come again and use the drug and we will have this vicious endless cycle. And for your question, so I don't think our data, our scope is sufficient to answer it. So maybe we need like much longer follow-up period, and we need some more rigorous documenting process to follow these patients up. Like if this patient is going to have this recurrent event, like having HCV again, is he going to be in UI Health to be recorded if you had this recurrence, or this patient will be diagnosed in jail, for example. So we don't know.
Yeah, I mean, I guess your paper's already written and submitted and accepted.
Yeah.
I was just thinking that you could incorporate some of the
This is a really good point. Thank you. Oh, good.
I'm not going to ask you a question. I just want to respond to what Simon's comment.
Okay.
So I don't think the policymakers were had that much forethought in terms of the implications of their policy. They're just trying to save a budget item, right? These are really expensive drugs. They're like, oh, how can we save some money in our Medicaid program? Let's put in challenges or doors that Abdulla showed to patients receiving these medications, which just shouldn't have been done, I don't think, in the first place.
I kind of heard the contrary in terms of some of these pharmacists that had said that they see patients get this treatment and then they end up reacquiring hepatitis, and it's like, we need to have some kind of way to incentivize them to, you know, not be in that situation. But that was more anecdotal. That's why I was really interested in this larger study where we actually get more than just, you know, a case or case series.
So, and maybe instead of restricting treatment, maybe those patients should be provided support to overcome their substance use.
And expand needle exchange program.
Yeah, for sure.
Not even needle exchange, just give them the needle.
Clean needle.
Yeah.
Okay, Hillary?
So I feel like, so DAA is pretty effective across different types of patients. So I guess this is the reason why you wouldn't see any difference between pre-policy and post-policy groups. Even among those like with fibrosis or even cirrhosis, maybe the new DAA is pretty effective and could lead to almost 100% SDR rate. So actually this is maybe some comments, like maybe the outcome of interest should not be SDR, because we would see the SDR be pretty similar across different kinds of group populations. But then, so the motivation of applying the sober restriction due to the cost, right? Maybe would it be like, if we have long-term data, maybe it would be worthwhile looking at the hepatitis, cirrhosis or hepatocellular carcinoma, the incidence rate of those complications of HCV.
Yeah, but we don't have like, so given our time frame, we don't have like the induction time for HCV to be developed through hepatocellular carcinoma. So it's not feasible from the data that we have. But this is more interesting, yeah.
Yeah, when we have like, when we have longer time of follow-up, maybe utilizing like claims to see the impact of policy change on the
Agree.
bigger scope. Otherwise, I wouldn't feel like if you use SDR as the outcome of interest, you wouldn't be able to see the impact of the policy by using that as.
So, like, okay, so this actually another counter argument to the policymakers. So if SVR is going to be high either way, so why restricting the medication?
Because they don't want to spend that much of money.
But their rationale was that patients with substance use disorder might have lower rates of adherence, therefore lower rates of SVR. And so this is one way to provide some evidence that
Why don't we just use the incidence rate of HCV as an outcome to check those states with restrictions versus those states without it.
So the medication is not preventive, so it won't affect the incidence. Is this your question?
Assuming the new HCV cases are coming from those going back to the injections, so restricting the,
like a treatment as prevention kind of thing is basically what you're saying.
yeah.
if you lower the rates of HCV within a state, then you should have lower incidence within that state, right? just lower transmission rates, potentially. Potentially, I think is the argument that Hillary's making.
So we are comparing on the state level?
You could.
Based on the
Yeah, this is another interesting idea. Yeah.
Can we get the data, like overall, like there are a lot of undetected.
Like changes in the instance within the Illinois versus changes in the instance in the Utah or somewhere else.
Yeah, this is interesting actually. I don't have this, may I have a question?
How was sobriety measured?
So it was measured by being free from any kind of abusing any substance, like alcohol, intravenous drug use, whatever.
Was it self-reported or?
Yeah, it was collected from the pharmacist, yeah.
Sorry, not.
The pharmacist was the one collecting these information, like if the patient's saying, oh yes, I have some problems with alcohol or drug use.
So were you concerned, because this would have been the pre-policy group, right? Post-policy group?
No, in both. Like, while you're documenting the patient profile, okay, like, do you have some history? Yes, no. And this is also, for the pre-policy, this was like a requirement.
Right. So were you concerned that the pre-policy group, there might have been some desirability bias? And if there was, then both groups would become more similar, and maybe that led to the null value?
So the pre-policy did not, okay, I understand your point, but like this, the status of sobriety was not disclosed before the initiation of the treatment. It was after. Like once the approval was there, so the patient confessed that, oh, in fact, I have some problems with sobriety.
Okay, but it was still a requirement to get the treatment, right? So maybe people in the pre-policy period just like
maybe
hide more.
Yeah.
Well, Michelle Martin, I think would be able to answer this, but I won't call you out, Michelle. She's the clinical pharmacist. She knows these patients, right? She would have, I think, a high degree of confidence about ascertainment of that information in both periods.
I was just thinking that maybe if there is a higher degree of people lying in the pre-policy group, then that would bias your results towards the null.
Yeah, this is a serious limitation. I agree with you.
But if there was no problems in the measurement, then this won't be an issue. But if it's a bias, then it would bias your results towards the null.
Totally agree.
I have a lot of confidence in the way that the information was captured, but you're right, that absolutely could be a concern. And we are out of time. I see somebody waiting outside. So let's thank Abdullah, and we'll see you all next week.